Greetings, everybody from India. Welcome to the CyberSight webinar series. And today I'm going to talk about managing myopia in the resource-limited settings. I went through the questions that have been submitted as a part of the registration process, and I've added the content that takes care of how do you manage myopia, what are simple steps to be followed. Then I have slides on what's the importance of axial length. Then how do you really go about preventing myopia in your routine clinical setting. These are my financial disclosures, but I would like to highlight that this lecture is not intended to endorse or promote any specific product. So if I look at the key words from the topic that was given, managing myopia in resource limited setting, I want to highlight that the first keyword is the managing myopia. Now we're talking about myopia management because it's no more a mere refractive condition, but we are now advocating it as a disease given the complications that are linked with the axial elongation. Just a few pointers. It's a new pandemic. We're looking at 50% approximately to have myopia by the year 2050. Then the costs are both direct and indirect. When I say the direct, of course, the cost for the consultation or maybe for the purchase of spectacles or any refractive correction. And then the indirect costs, which are less discussed, are the psychological stress the child has to go through, or the bullying that the child undergoes if he or she is a high myope, and the occupational limitations that they may have. I think a lot of indirect costs which are less discussed. And the third one is to say that myopia is multifactorial. Unfortunately, the cause still remains unknown. I think there is huge scope for all of us to contribute to this profession to combat myopia. Good news is it can be prevented. We have multiple solutions right now. I will take you through that in the next few minutes, and progression can be controlled. We have various myopia control options that are made available thanks to the industry, which is helping us to combat myopia much more effectively. But all in all, the myopia management is beyond single vision correction. Now, I use the word myopia control, I use the word myopia management, and I also use the word myopia. Now, what are these terms? There is a recent publication in the IOVS in the special issue by the Flitcroft et al. As a part of the International Myopia Institute, nicely indicating when to use myopia correction, when to use myopia control, and when to use myopia management. So let's spend some time at the starter to go through these definitions. Correction, as the name itself indicates, we are just talking about correcting the refractive error. As it's written there, devices and interventions that correct the optical focusing errors without providing any benefits in relation to the myopia control or in relation to the slowing the progression of myopia, or you're not talking about regulating the axial length or controlling the axial length. This is only correction. You give the correction to ensure this best corrected visual acuity, and you're not worried about any of the changes that are happening in the eyeball length or the refractive error. As the name indicates, it's correction. Now let's go to the control. This is a clinical application of the evidence-based interventions, specially intended to slow the progression of myopia and the axial elongation. Now, the first one was the correction. Second, we are talking about the control. What do we control? We're talking about controlling the progression of myopia, and we're looking at the change in the refractive error and also the change in the axial elongation, and we're putting them on some sort of treatment strategy to control these changes. This is essential component of the myopia management, and it involves the regular monitoring. So it's not one time, it's not like the correction, but you're saying that, okay, I'm correcting now. I'm also aiming at controlling the progression of myopia for which I need to monitor much more regularly. And the single agenda worldwide, if you are in myopia, you want to be at the back of the eye, stopping the elongation of the eyeball. What is myopia management? It's a much more comprehensive eye and vision care, I would say the comprehensive term, where we're talking about the vision care approach. You talk about myopia, you're talking about pre-myopia, the early detection, myopia correction, myopia control, monitoring, and also the management of complications. So this is the diagram that I want to highlight. You look at prevention, which means you're also looking at not somebody who developed myopia, but also somebody who is not developed myopia yet. And you could label them as pre-myopia, a younger age, risk of developing myopia because there is parental myopia positive, and then the age is only 6 to 7. The refractive error is not so much in the plus side, or less than the plus 0.75 diopters. You prevent myopia, you're looking at controlling the myopia, you correct, and also you identify children at risk for the serious complications, you manage the complications as well. So that's a holistic gamut that we're looking at when we talk about the myopia management. Now, how do you manage? You have multiple solutions to control the progression of myopia, all the way from the lifestyle modifications to prescribing bifocal spectacles to the contact lens. In the contact lens, we're talking about multifocal contact lens. We have extended depth of focus contact lens. We have orthokeratology, or the nighttime wear contact lens. In spectacles, we have peripheral defocus spectacles. We have the famous eye drops that are the low dose atropine, widely used since few decades already, and the more recent diffusion optics technology. So now on the right side, you are seeing a forest plot that shows that when you do a systematic review, we realize that the various treatment options do indicate good efficacy in controlling the axial elongation. What is important is undercorrection does not work. Undercorrection did not give good outcomes for controlling the progression of myopia. Of course, high dose atropine standing very high, but the side effects or the complications with high dose atropine need to be kept in mind. And we have various corrective options or the controlling options in the spectacles or the contact lens as well. Now we looked at what myopia management is. Now let's look at the other term that is here right now. What is resource limited setting? Now I did some search and then bumped into this Van Zyl et al.'s publication in BMJ Global Health, published in 2021, which indicates a resource limited setting or a low resource setting indicates either there is an inadequate infrastructure, shortage of the skilled personnel, limited access to technology, low awareness, or the practice is more belief dependent instead of the evidence based. Then there are challenges, especially in geographic and monitoring of the health, and then overall leading to the suboptimal services. Now, this nicely fits into the myopia management that we are talking about. From whichever country you belong, I think all of us are belonging to a resource limited setting. If you look at either the people managing myopia are really limited, which means there is shortage of skilled personnel. If you look at inadequate infrastructure, we talk about specific infrastructure. You need to start myopia clinic, so maybe there is lack of infrastructure there. Limited access to technology. A couple of slides before this, I've indicated that there are multiple myopia control options. Now, to whatever country you belong to, I'm sure there is limitation in acquiring them, or there is lack of some approvals. We are not having either spectacle option, or we may not have atropine option. For example, from the context of India, we don't have the higher concentrations of atropine. We don't have dot technology in India yet. We do not have MySight, but we have others. Now, if you're coming from a different country, you can relate to, you may not have all these available technology with you, making us located in a resource limited setting in relation to the myopia context, I mean. And low awareness, clearly, a lot of publications much more recently indicated there is a lack of awareness among the stakeholders about myopia and its management. Number one, the practitioners are not aware when to start, when to stop, what needs to be done as a part of the myopia management. Number two, the parents are also not aware that the myopia progression can be controlled. And we also lack the monitoring equipment or monitoring systems. For example, we say that lifestyle need to be monitored, the behavioral modifications need to be made. But I think not everybody has access to the trackers that can do the job for quantifying children spending time outdoor. Right now, people come to the clinic, we ask, okay, how much time do you spend outdoors? The child can say 1 hour, 2 hour, but we do not have any quantifiable variable to say that, yeah, I now confidently can say that the child is really spending only 2 hours. That's where we lack. And at the end, I think we are providing suboptimal services owing to not having access to any of these parameters that I've discussed so far. So we are at the resource limited setting when we talk about myopia. One of the resource that we always talk about when we talk about myopia is axial length. Now, I want to understand what's your perspective is if you think measuring axial length is important in myopia practice. So you can say, yes, it's a game changer, or you can say that it's good to have, but not important. You can also say axial length is not an important parameter. You can also say you're not sure. I don't have to convince the audience that axial length is really important. Okay, but about 11% of you think that it is not, it is important, but it's okay, good to have. All right, great. Thank you for your feedback. But let me share with you my 5 reasons for why axial length is important. Now, I did a quick search, and renowned people in the field have written nice articles emphasizing the importance of axial length in myopia management. If you look at the top, I really like this title, which indicates, should myopia management be renamed as an axial length management? Now you will see that I looked at the questions that were indicated during registration, and I had added some slides to ensure I cater the questions that were asked. But if there is any question, you can always drop in the chat box as we proceed. So my 5 reasons. Number one, clearly when we talk about myopia, we are definitely worried about the axial length. We all know that the greater are the risk of complications when the eyeball length is much more longer. And I have indicated already that single agenda that we are in right now is to control the axial length from growing, or the eyeball from growing. And the debate is also there about, hey, is it really a refractive condition or it's a disease? Owing to the complications, more recently, the scientific community and the clinical community is advocating it as a disease given the complications and the risk of visual impairment. Now, what does the IMI say? IMI stands for the International Myopia Institute, and it clearly indicates, if available, axial length measurements should be taken at every 6 monthly. So that's the importance of axial length that we're talking about. Now, what's the reason number 2? When we talk about myopia, there is also this aggressive type of management that goes in with all the available technology that we have, or all the availability of the various myopia control solutions. And we tend to prescribe these lenses left, right, and center at times. Now, I want to emphasize that all myopes are not necessarily axial myopes, for which, unless you have this axial and measurement, it will be difficult for you to understand what type of myopia it is. Now, if I give you this example of 10-year child with -7 myopia, straight away we think, all right, the myopia is already on a higher side, child is young, let's start myopia control treatment. But if I show you this axial length, it's only 22.7. Clearly, it's not really correlating. And the other eye is also showing 22.6. cornea is also, the keratometry values show 43, not so steep cornea. Now we did a cycloplegic refraction and we realized that, it's +1. So it's important that we understand different forms of myopia that we have. It could be refractive myopia, cornea could be steeper, lens could be thicker and steeper, or it could be the anterior shift in the lens, anterior positioning of the lens leads to more myopia. It could be the changes in the refractive index leading to the myopic shift as well. But all we are interested is axial myopia, for which you might want to have an estimate of what an axial length is. As I said, not everybody is an axial myope. There are pseudo myopes. These days, it's getting increasingly common with the anxiety, with the stress, with the strive for academic excellence. I think it's important that we eliminate these pseudo myopes. Keratoconus also is not that less common. The numbers are increasing, and it's important that we diagnose keratoconus and not give the myopia control treatment just because they have myopia. Unlike myopia, now if you're looking at a pseudo myopia, their axial length is not so much, always at least. There will be at times myopia, again there's pseudo myopia as well, but usually one point to note is these are not really the longer eyeballs. So that's something that you might want to keep in mind. Reason 3 is control in refractive error does not always mean control in axial length. Myopes have better depth of focus, better blur tolerance, and then even there is change in axial length, they will not accept the new power. So it's important to have that axial length estimate. Now this is an example. On the left, you are seeing one of the cases that I had, and maybe if you concentrate on this last two lines here, third, which is March 2023, eyeball length is 25.67, and in October 2023, it increased by good 0.3 millimeter. 25.67 became 25.96. Whereas in the left eye, 25.52 became 25.74. Now you're looking at 0.3 millimeter change in the right eye and 0.22 millimeter change in the left eye. But if you look at the refractive error from the present glass prescription, it was -2, and then it was only -2.25, and there was no change. But it gave me a clear insights on the, there is clear change in axial length. Let me still try and intervene for controlling the axial elongation. The cornea was a little flatter in this case. That's where it was not really correlating. Now, the fourth reason for why axial length is important to have is these instruments have a very good resolution. It will help you to understand small changes as well. The resolution of these biometers, I'm talking about the non-contact biometers like LensStar or the IOL Master or the Myopia Master. These have a resolution of 10 micrometers, which is 0.01 millimeters. Even the small changes, you will be able to pick them up. And the fifth or the final reason that I have is it gives a lot of confidence. The moment you know that, all right, I'm seeing this, changes in the eyeball length correlate with refractive error, my treatment, is it working or not? For example, if you see this case where I have given the bifocal, for example, in the first 4 months, there was no treatment and the eyeball length changed by 0.18 millimeter in the right eye, and bifocal spectacles were prescribed, and in next 12 months, the changes were only 0.12. Now, having this value gives me an indication that after I started the treatment, the eyeball length changes are only 0.12, which is much more lesser than what it was in just 4 months. And same is the case in left eye. Without treatment, in 4 months' time, eyeball length increased by 0.16 millimeter. And in the next 12 months, the changes were of the magnitude of 0.14. So whatever happened in 4 months, with the treatment, we could sort of control it for the 12 months duration. Now, this gives me confidence to say that, yeah, my treatment is working, hang on, continue with the same treatment. Now, this is another case where for the first 1 year, the child was on the extended depth of focus contact lens, and you see that the changes are of the magnitude of 0.08 millimeter in right eye and 0.02 millimeter in the left eye. Pretty minimal, great. For some odd reason, child decided not to wear these lenses after 1 year. They came back in 4 months and suddenly there is an increase. Now this increase is only with a single vision. They were not on any myopia control treatment, no need of contact lens, no myopia control treatment, only single vision spectacles were worn, and you see that there's a big jump. Because of this axial length measurement available, I could say, yeah, there are significant changes. I don't want to wait and watch, and let me put you on the MyoSmart lens again, because child was not interested in the contact lens, and we could bring back the changes. So that's good to have. So these are 5 reasons for why we need a biometer. Now, traditionally, maybe 2 decades ago, ultrasound systems were used, the A scans, to get the axial length measurement. Now, this is contact technique, relatively invasive measurement, because you are touching the cornea, there is high risk. You need a skilled personnel to get the measurements done, but this is inexpensive. The talk is concentrated on what do you do if you're in a low resource setting. Now, you cannot afford the biometer, don't worry. This is cost effective, but it comes with its own costs of, the side effects or the need for the skilled personnel. Tons of biometers that are already available. Now, if you're worried, is this showing good agreement? Can I use this? Is it comparable to IOL Master or the Lenstar, which are considered as a gold standard? I think there is enough evidence to say that the axial length measurements are comparable. And this is a recent publication. I pulled it out to show the Bland-Altman plots, which are showing that the plus minus the 95% limits of agreements are about plus minus 0.2 millimeters or relatively lesser than that. So you will get definitely an estimate of what an axial length is. Any measurement is a measurement, and something is better than having nothing. Now, what could be the future? What's already in the present is these are the devices that does both refractive error assessment and also the axial length measurement along with the keratometry values. This is something that we validated a year ago, and it showed good outcomes in comparison to the Lenstar. What's coming in the future? You see me smiling, very happy, because I was looking at this new device from the Pristine. It's called OBM 12 because it gives 12 variables in one shot, and I was smiling because it could complete the measurement of both the eyes in just 25 seconds. And we are, doing a validation at this point of time. This is work in progress, but I thought I will show you 2 examples. This is an emmetropic eye where the top panel shows the data from the Lenstar, and the bottom is from the OBM 12. You see 22.42 is 22.45, not extremely different. Same is the case for the left eye, 22.11 millimeter axial length, 22.17, great. And if you take a high myope, 27 millimeter axial length, here also 27.07. In the left eye, 28.7 with Lenstar, and you see the highlighted region, 28.69. So it's great. This is work in progress, and stay tuned to get more updates on this. So far, the message from my last few slides was axial length is an important parameter. If you can collaborate with somebody, if you do not have axial length, I think it's great. We will move forward with the next section of my talk, which concentrates on when do you start treatment, what's the protocol that you need to follow. Now, before that, do you think we should start myopia control treatment for all the myopic children, given the associated complications? The moment you see a myope, you want to start treatment. No, not for everybody, or you are not sure. All right, great. So majority, 63% felt that yes, the moment you see a myope, you should bang on, start the treatment, and 30% indicated not for everybody. All right. The answer for this will come in the next few slides, and let's see. Now, when you talk about the myopia management, wherever you are, again, we're talking about low resource setting. We developed these guidelines called Impact Myopia Management Guidelines. These are just 6 steps. IMPACT, developed when there were combination of the scientists, were optometrists and the ophthalmologists, and we came up to a consensus and we developed this Impact Myopia Guidelines. I know that there are about 40% of you indicated you were willing to start myopia management. If you're unsure where could be a starting point, please remember Impact. This could be your first step. So let's go step by step. The first one is I. I stands for Identify True Axial Myope. I've already indicated that not everybody is an axial myope. It could be mere steeper cornea, it could be just the anterior positioning of the lens, or it could be a thicker lens leading to myopia. And for them, there's no need for us to start myopia management. There's no need for us to start some sort of myopia control treatment. So first step is, if you're good in refraction, if you use retinoscope, identify that there's no split reflex, there is no keratoconus. Then if you can look at the keratometry readings, if you have auto-ref keratometry, these days they give the keratometry values as well. Understand that there's no steep cornea, and this is really axial. So eliminate refractive cases of myopia, eliminate pseudomyopia, eliminate keratoconus. I think these are largely the ones that comes to us when you are starting your myopia practice. Map risk factors. Now, myopia is multifactorial. According to me, it's sin to start myopia treatment just based on central refraction and the visual acuity. We know myopia is multifactorial. The combination of genetics, environment, when we talk about environment, light, near work, a lot of parameters play a role. A lot of times, mere lifestyle modifications can do wonders. For doing lifestyle modifications, you want to understand what sort of behavior the child is living in. Is the child having closer working distance? Does the child spend a lot of time on the screens? Does the child bend and write? What sort of posture that the child has? What type of outdoor environment the child is living in? And if you have retinoscope, get the accommodative error value. Is it lag? Is there a lead? Is there an esophoria? In our clinic at LV Prasad Eye Institute, we also do peripheral refraction. You can use open field auto refractor, or you can use, we recently developed something called SPAR. You can use like a trial lens. It sort of enables you, using the retinoscope, you will be able to understand what sort of reflex is it. Because the relative peripheral hyperopia is considered as a triggering factor. Now, if you have esophoria with lag, maybe bifocal spectacles might be better off. If you have relative peripheral hypermetropia, maybe the peripheral defocus type of spectacles could do the job, because there are studies that show that the treatment options that target periphery of the eye were little less efficacious if the pattern is already myopic. So you want to target somebody with relative peripheral hypermetropia based on the evidence, and then maybe you will see good outcomes. So mapping risk factors is crucial, apart from the refractive error and the axial length. Now pick a progressive myope. When I say a progressive myope, understand that there are changes in the axial length, there are changes in refractive error. For example, if you look at the case one, 10-year young child, but since 2-3 years, the power did not change. Now, when there is already a stable refractive error, why do we trigger for some unnecessary treatment? Now, case 2 is an example where current glasses are -5. When I do refraction in the clinic, it's -6. So I start in case 2, but not in case 1. And this is important that we pick a progressive myope. Advise appropriate treatment because there are multiple treatment strategies that are available. You might want to pick a right strategy to combat the right risk factor. I have already indicated that at times lifestyle modifications do wonders. We're talking about myopia prevention, we're talking about myopia control. Lifestyle modifications can be included into your prescription strategy. Now, for the myopia, you want to consult regularly, 4 to 6 months. You will see some change. If the rapid progressors, you will see the change in refraction. If there are not so rapid progressors, if you have an axial length measurement device, you can call them in 4 to 6 months, map the changes in axial length. You will be able to do justice because you have an understanding of what trajectory they are in. Combined treatment, you start with mono treatment. So at least I start with mono treatment first. And once the treatment did not work, they are non-responders or poor responders because I gave a treatment, I waited 1 year, eyeball still went on to elongate in the same manner without treatment and with treatment. And I say, all right, seems like there is no response. Let me combine treatment. I think this is very important to combine treatment when one treatment does not really give you good outcomes, and monitor regularly 4 to 6 months. Another $1 million question. When do you stop? T stands for tapering. If you are in atropine, there are studies that are coming up to say maybe for atropine, keeping in view of the rebound, you might want to taper and then stop. But I want to indicate you might want to consider late teenage. If you started treatment, I think until late teenage, there is chance of myopia progression. Monitor closely for the 2 years. If there is no change in refraction after intervention, and if they are touching that late teenage, maybe that's when you are thinking, all right, maybe I should now take them off from the treatment. Monitor regularly. Do not leave them off. Monitor regularly, even when you take them off from the treatment, because you might want to see if there is any rebound. There are reports that are indicating that even with the optical strategies, there is a rebound. In fact, one of the cases that I've shown, I don't know if you want to call that as a rebound, once the EDOF lens is taken off, just in 4 months, there is an increase. So in that case, you can always restart the treatment. So now again, why do you think late teenage? Now, if you look at the refractive surgeons, they operate at a late teenage, or maybe somebody's 18 plus or 20 years of age. They are looking at the stability, they are looking at the stability in the axial length. Same analogy can be applied to myopia. We're also looking at eyeball length. We're also looking at stability in the eyeball. So same analogy can be applied for why late teenage is are good. Now, so that's about the impact myopia guidelines, and I will give you the India context before I talk about the preventive strategies. Now, in India, we published this paper in the year 2020 actually, and then where we said that the Indian trajectory for myopia is also similar to the global arena because we're also looking at 48% of the children living in urban population or urban cities to have myopia. Even in India, we have clear differences in myopia prevalence between the rural and the urban population. Let's say if in rural it's less than 5%, whereas in urban cities we have it's touching about 25% as of now. I'm talking about 2025. We're looking at 25-30% of myopia prevalence in children aged 5 to 15 years. And if we talk about progression, 20% of them have rapid myopia progression. Now I've indicated that why do I give treatment to all myopes left, right, and center when the progression itself is not in everybody. It's only in 20% of them who are rapidly progressing. And this is where we may want to target. In fact, not everybody also will have progression. So there are a few stable myopes from the beginning. So for them, maybe you may not want to do anything there because they're already stable. Now, the unfortunate thing is the indoor-centric lifestyle that we have right now will escalate things. I think we're going to see more myopia across different regions given the indoor-centric lifestyle. Now, one of the best strategies that we have is the environment lifestyle modifications, time outdoor as a preventive option for myopia. Now, why time outdoor? There are multiple reasons. As you see on the screen, that the ambient levels are much more higher. if I'm outdoor, my accommodation is much more relaxed because I'm looking at something far away. Then the spectral composition is very different, indoor and outdoor. The exposure to UV is higher. There is debate about is UV really productive, not, but dopamine release is also known to be productive for the axil elongation. Various theories, again, these are all proposed hypotheses for why time outdoors could be great. Now, environment modifications cannot be only light, but also, but we should look at the near work as well. Now, we did this overview of systematic reviews a few years ago. We indicated that the light exposure, outdoor light exposure, is good for myopia prevention. However, its role in slowing the progression remains sort of controversial, given the clinically insignificant values that you see. For example, mean reduction was not so much. Now, but is it really light? It's difficult to tease out. It could be a substitution effect also. Number one, it's great for myopia prevention, for sure. Now, purely if you're in outdoor environment, is it really time outdoors that's controlling the myopia? Maybe not, but it could be a substitution effect. I've already alluded to various theories. Which one could lead to the control? We are unaware at this point of time to pinpoint and say this is the only reason, but it could be substitution effect because you're not doing near work if you are in the outdoor environment. Now, when we advocate or when we recommend the lifestyle modifications, I realize that these are oversimplified. We say, okay, time outdoor, increase time outdoor, 1 hour time outdoor, but we are not saying or we are not indicating where outdoors. For outdoor environment, they could be playing under a tree, under the canopy, or between the buildings, or it could be in a parking area where there is no sunlight. Now, if you see these light exposure levels, we did this study, a simple study looking at what's the illuminance levels are in different locations. And if you concentrate only on the direct at the sensor at the level of eye, the light levels are higher only in open area and if you're in translucent shade or under the portion. But if you are under the tree between the buildings, the light levels are really low, which means the child is outdoor, but does it have beneficial effects on myopia? I mean, it's debatable. So maybe in our recommendations, we need to mention it clearly that when I say outdoor, it has to be preferably an open play area, maybe. Then the other entity we looked at is the spectral composition is very different as you go from outdoor to indoor. Now, much more evolving, the recent trend is also to see which spectrum of light the composition is really playing a role. Studies, we did this study in 2021, and we found that the blue light exposure on a short-term basis led to the or did not increase the eyeball, let me put it that way. Whereas the red and the green colors, the exposure, the red light and the green light exposure led to increase, whereas blue light did not lead to an increase. Now, I also want to acknowledge that renowned people in the field are looking at this light exposure, and studies indicate there are few reports to say red light is working great. There are few reports to say violet light is working great. There are few reports to say sunlight is working great as well. So I think this is an area that we need to watch out for, and this is me with the wearables that we are testing in the lab. We are very much open, looking at what wavelength of light is really good in the long term. Now, a few other questions that come, is reading on a hard copy same as the reading from the smartphone or watching a video? We found that reading from hard copy led to greater changes compared to watching on a video. So video is it's moving, the content is regularly moving. You don't have to accommodate as much compared to reading text on a hard copy. So I want to highlight that people think or assume that smartphones are the culprits. Please understand that first smartphone came in only after 2000 year, whereas myopia prevalence already peaked before 2000. So clearly it's not smartphone, but maybe any sort of near work could be triggering for more myopia. Now, another question that people ask is it near work, time outdoor, what it is? We did an experiment in the lab where we said same individuals read at 20 centimeter away from the eye, same content indoor and in the outdoor setting. This is outdoor, bright sunny day. People were reading pre and post. We got the eyeball length measurement, and indoor, same distance, again, same people. We mapped what is the exposure. We found that near work, wherever you are, indoor or outdoor, does not really matter. It is going to trigger for the changes in the axial length. If you're outdoor not doing anything, then that's better compared to if you're outdoor and reading. Now, if maybe you will ask, you're thinking why this experiment is really relevant. At times, parents ask, I mean, this question has originated because one of the parents asked me, I want my child to concentrate on academics. I will put that child in a balcony setting, in a patio, or in an outside, but I want him to read. Will the outdoor effect still be beneficial? So clearly it is not. So maybe our recommendation should indicate more outdoor activity, not reading, not no near work. And if you are starting your practice, if you do not know where to start, you can, this is something that we developed at LVP. I will just play that. You just have to feature in what's the age of the child, what's the current spectacle power, what's the previous spectacle power, time outdoor, 4 parameters, and it will indicate if you are at low risk or high risk for the myopia progression. So this is already scientifically validated and you can access it from here. Again, this is available for from wherever you belong. To summarize, I want to indicate that so far we started off with what are the definitions for myopia correction, myopia control, myopia management. Then we discussed about the importance of axial length measurement. We spent some time on understanding ultrasound technique versus non-contact biometers. Then we discussed about the impact myopia guidelines. And at the last, I focused on the preventive strategies and how these myopia recommendations on lifestyle are sort of oversimplified. We shouldn't do that. So myopia management is beyond single vision correction. There are multiple options that are available. Actual length seems to be an important parameter. It will give you a lot of confidence if you want to start. Either you collaborate or you get a device that can help you to get the values. Now, these days, we also have, I did not tap onto this, but you can also understand what's an approximate axial length is using various equations. Impact guidelines, you want to start, 6-step guidelines, easy to follow. Lifestyle recommendations are oversimplified currently. This is not great if you want to see good outcomes. One case at a time. Each case is extremely different and one size does not fit all. With this, I would also want to invite you to join us for the 5th Indian Myopia Awareness and Research Conference. This is conducted in Hyderabad, India. And that's my details there. For anything that you want to contact, I can be contacted via email or WhatsApp. And I want to acknowledge the support that I get from various industry partners and the wonderful team and collaborators. Thank you for your attention, and I'm happy to take any questions. I will look at the chat box and I will. Okay, first question is, what if we don't have access to excellent measurement equipment? I think not a problem. I am not saying that excellent, without that, you shouldn't start myopia management. You should be smart enough to rule out the refractive cases of myopia, number one. And number two, like I said, there are some equation-based applications that are coming out. You may want to use that or try to collaborate for gaining more confidence. Like I said, it will give you that extra boost if you have that excellent measurement. what is the most cost-effective axial measurement tool? I've already indicated. I mean, you have various devices. I think more recent ones are looking at making it cost-effective. I know OBM12 is trying to do that, and you have something called portable axial length device. I think not commercially available yet. It's called Acuity, that might be available soon. Then if you want to do contact, then ultrasound is definitely relatively inexpensive compared to the non-contact biometers. Which medical instruments are used to detect myopia? I mean, see, myopia is a refractive error. You might need to have the refractive error value. You can use autorefractor, you can use open field autorefractor, you can use retinoscope to understand what sort of refractive error it is. And that's your answer. And yeah. What about drugs induced refractive? Yeah, I think there are a few drugs that also induce refractive myopia. Again, when we talk about myopia management, myopia control, it's all about the change in the axial length. Now, anything that's not axial myopia, we should not be even looking at providing the treatment to control the axial length. You should be treating cornea, you should be treating lens, you should understand what could be triggering. At times, no treatment is required. For example, let's say there is a case of -4 diopters of myopia, and axial length is 22 millimeter, but cornea is 47 diopters or 48 diopters. You know that the steep cornea is leading to the myopia that we are seeing. Okay, then drugs is done. Can you explain session whole education career for aspect? No, I mean, optometrists have huge scope to contribute to the myopia. If you're an ophthalmologist, again, there are a lot of complications that to be dealt, again, because of the stretching of the eyeball. The scope is humongous. It's huge. If I quote Professor Brian Holden in one of his publications in 2011 or 2012, if I'm not wrong, it clearly indicates that the eye care practitioners should be in the front line of this battle, and we need to combat myopia seriously. Okay, there's a question in Spanish. Unfortunately, I cannot understand Spanish, but I'll try. Importance, got atropine, control the progression de myopia. Okay, atropine, if you're asking me, how does atropine controls myopia, there are various theories that are proposed for why atropine could help in regulating the axial length. Studies also indicate it's working in the non-accommodative mechanism. Atropine in India, we have only 0.01%, unless you want to compound it. There is also a debate about, hey, is this the placebo? Is it really working? With one of the recent publications. But various studies indicated that atropine is showing good outcomes. The complications for the low dose are relatively less compared to if you use higher dose. You know, for me to convert that Spanish to what I understood, I tried to explain it there. Shall I contact you to know more about eye diseases? Yeah, please. I think I'm happy to get connected via email. I have my email ID there. Then can you please share your words on diffusion? I think diffusion optics technology, there are theories coming along to say that you play around with the on-off pathway, and that's known to control the progression of myopia. More recently, I think there are 2-year studies that were released, which is showing fantastic efficacy for the diffusion optics technology. Again, in India, I do not have first-hand experience of using it, but the research evidence seems to be quoting it as high. Do you think undercorrection needs to study really well to see its impact before we abandon the treatment modality? I agree. I think this is great. Undercorrection, there are limited papers to say that undercorrection does not work great. Now, if you probe deeper into the changes in axial length, what's the mean deviation, these are not extremely negative as well. There's one study that shows undercorrection works, one study that shows undercorrection doesn't work. But I think, yeah, it's been ignored. More studies are definitely warranted. What understanding we have until now is that undercorrection is not helping in controlling the progression of myopia. Now, will it aggravate? Will it be stable? Will it not do much effect? So that's where we sort of abandoned. But given that there are much more better treatment strategies, I think the clinical management completely shifted towards using various myopia control options. It could be the Stellest or Myosmart or Myocare or various myopia control lenses that are available. What's the significance of peripheral refraction in myopia management? Good question. Again, see, the defocus lenses, as the name itself indicates, were developed to counteract the hyperopic defocus. Now, if that's true, you might want to give this treatment option for somebody who is having relative peripheral hypermetropia. So relative peripheral hypermetropia, you put them on myopia control lenses, you will make it more myopic, so you might see good outcomes. So that's where, if that philosophy is true, then understanding what pattern peripheral refraction the person have may add value. But I think I must admit that this is really debatable, with some publications indicating its usability, some publications indicating maybe it's not really useful. In fact, one of our recent publication in IOVS, we have shown that based on spherical equivalent alone, you can have 9 different patterns of peripheral refraction. For example, relative peripheral hypermetropia in temporal meridian, nasal meridian, relative peripheral hypermetropia in temporal, but relative peripheral myopia and other meridian. So all sort of combinations are possible. Do we have an understanding if this is a specific pattern? I think maybe we need more research on it at this point of time. Effective information about the effectiveness of spectacle lenses in orthokeratology atropine are not very easy to obtain. Yeah, agreed. There is enough evidence, William, on the various myopia control options. Again, there are a few studies that go to 7-year outcomes, 6-year outcomes. I think all this is readily available. You just want to type in efficacy of myopia control lenses, you will get it there. We have done a living systematic review in Cochrane. You can also search for it, living systematic review on interventions to control myopia. I think that will be a good summary for you as well. When should I consider stopping for my patient who is 11 years, stable refraction for 4 years? Yeah, interesting. So like I said, usually I would wait for that late teenage, because 11 years, you may have a growth spurt. Again, everything changes. So that's where I want to be a little conservative on my approach. I would wait for some time till they get to the teenage, and then slowly, maybe if you want to take them off, if you're confident that it's really stable, unchanged axial length at all, then maybe take them off for 4 to 6 months, see them in your clinic. Even if there is a change, it should be really less, and you should be able to manage it. Red light therapy, this is evolving. There are multiple clinical trials conducted, especially in China, showing good efficacy of red light therapy. There is some concern about its safety and requesting more longer duration clinical trials, but the studies conducted in China indicate good outcomes at least. I do have Spark but lack guidelines. Yeah, I think my team member Shaubik has messaged already that you can contact me and we will be able to take care of that. Myopia control is better, atropine or I mean, it's difficult to say which is really better. Everything has its own positives and negatives. When you sit in front of a patient, while we theoretically think that, okay, because of A, B, C factor, I want to give this specific treatment. But you need to look at what is the cost, what can they afford, can they be compliant, can they be Coming back to the follow-ups, can they wear this lens? I think multiple options comes into the picture, but I'll give my view. For me, anything that can take care of the correction and control in one shot is better. Because to see things, the myopes have to wear any correction, either in the form of spectacle or contact lens. You can start with that so that in one shot, you're hitting two things. One, correction. Number two is controlling the progression. Compliance is better because they will always wear spectacles or contact lens. The compliance is also better. Now, the consciousness, the parent doesn't have to worry too much about putting a drop, about worrying. So they just, okay, it's a regular spectacle, leave it, and then there is less stress. The only worry right now is the cost that we need to look at if you're looking at optical correction. But the future looks bright. I hope we will have more cost-effective strategies. How do you correct pseudo myopia? I mean, see, you might want to do a proper refraction to pick this up. At times, there is no intervention required. It depends on what type of refractive error they have, and then you will treat the pseudo myopia. So you might want to do a cycloplegic refraction. You might want to do atropine refraction if required to really get that lens not so fluctuating. All right, which myopia control treatment? We covered that. That's Tahif. And then we have Manmohan Lal Shrestha. Up to what age we can use atropine? Any treatment, my reference is late teenage. Late teenage, 2 back-to-back years, stable refraction, you can think of removing them. Now, if the refraction is not stable, you should treat them even in their young adulthood. I have patients who are 20 plus, still on myopia control treatment. And yeah, so age is only a number. Can you tell more about pristine OBM12? Maybe you can email me. I can talk about it more for more details. It's a non-contact biometer. It does 12 parameters in one shot. It gives measurements of axial length, all the 12 parameters in just 25 seconds. We are validating, and it's a non-contact sort of biometer. Okay. Then we have how to control progression of myopia. If it's rapid, again, various myopia control treatment options are available. You might want to pick appropriate treatment. Understand the risk factors. What is the risk factor? If lifestyle modification can do the job, leave it with lifestyle modification. Start with mono treatment. If that doesn't work, go to the combination treatment for myopia. What else? Rebound effect. Yeah, I mean, this is interesting question. This is Sanikant from, okay, I don't know from, but can you explain rebound effect of myopia treatment? See, the atropine especially is known to cause rebound effect. You are on treatment for some duration of time, you take the treatment off, suddenly there is jump in the refractive error and the axial length. This is not good. This is rebound. Now, so to avoid rebound, you may want to taper the dosage, or you may want to add some other treatment, or you want to monitor closely. If you take the treatment off, monitor closely. If there is significant changes, you should restart the treatment. What would be essential set of tests establishing myopia in my practice? I think the first set of course, a good refraction, understand a detailed history, develop a medical record system where you can capture so the parents also understands. Educate them. I spend a lot of time educating what myopia is, why I'm giving a specific treatment. You need to give extra chair time. Otherwise, the child will not understand what you're doing. The parents will ignore the consequences of the treatment. Have a proper information to educate the child and the parent. Refraction, if you use retinoscope, understand parameters related to accommodative error. Is there a lag lead? Phoria assessment. Is it esophoria, exophoria? If you believe in peripheral refraction, you use retinoscope to do the refraction in the periphery of the eye. If you don't have an open field autorefractor, obviously. Yeah, axial length, cornea readings, I think these are very good to have. If you have auto-ref keratometry values, I think the K readings are really helpful. When I look at the A scan, I look at the age, I look at the A scan, axial length value, K readings, anterior depth, anterior ACD, and the lens thickness. And in one shot, it gives me a picture. Is it really axial or non-axial? So if you have a biometer, it's great. It gives you a lot of information. But yeah, retroscope, accommodation parameters, lifestyle, detailed documentation of lifestyle. What do they do? What's their working distance? What time do they go out? Where do they spend outdoors? I think these are all important questions to be asked. What is the latest age? I think, see, the clinical trials are conducted from the age of 5 to 6 years. I think largely 6 and above, because you might want to factor the emmetropization, the change in the various ocular parameters. And above 5, you're good to go. And like I said, the upper cutoff, it could be anything. If there is axial length elongation, you should continue with the myopia control treatment. Uh, Parents also have myopia. What would be the environment change? What would be the environment change to be done? Jennifer Stalin, if the child's parents also have myopia, yeah, I mean, clearly, if the parents have myopia, it increases the risk of myopia in the child. So, if the child does not develop myopia yet, you label them as pre-myopia. If they are young, the value is closer to the emmetropic value. You will say that, okay, you're pre-myope. I'm not starting you on treatment. Lifestyle modifications, go outdoors every day, maintain posture, maintain distance for the reading material, minimize screens as much as possible. I think these are things that you might want to indicate and monitor closely. Lens material matters. I don't know. I mean, a lot of these lenses come in the polycarbonate. I do not know if the material of the lens in itself has any has any uh, role per se. But now there is debate about the blue blocking lenses. Are they good? There is debate about which wavelength is good, which wavelength is bad for the eye. So at this point of time, blue blocking lenses people use for relieving the asthenopic symptoms, if they're really on the screens, etc. But scientific evidence does not add a lot of value for that. So number one, lens material, I'm not sure if that has any role, and I'm just adding an extra layer to the blue blocking lenses. I do not know if that will add any extra value as well. Advise appropriate myopia control strategy. Yeah, when I say advise appropriate myopia control strategy, it's about looking at the multiple options, what could be triggering in that individual, and you discuss A, B, C, D, E options, and then say, according to me, this could be the best option for you, and this again, it comes with the costs, it comes with the compliance, you need to look at the patient, the child, and the environment that they live in, and then put them on some sort of appropriate treatment options. Can digital screen exposure guidelines be realistically implemented in areas with limited education and awareness? Digital screen exposure guidelines, uh, what you have raised is an important and sensible question. We say minimize screen time, stay away from the screens. Is it really practically possible? I have my own reservations. In fact, few of my patients also ask me, "Sir, you're telling this, so great, but I have my homeworks to be done on the screens." Now, it's also unfair for us to keep this generation away from the screens, right? I mean, I think there's something sensibly they have to use. Uh, you cannot say get away from the screens completely, but I think we also have on-screen technology which monitors how much time you are on the screens, how much distance that you are using. Maybe these sort of technologies will evolve in the future. Maybe it could become a new normal for everybody to have that inbuilt. For example, these days we have the smart watches where you monitor you count the steps and then you worried about the health. Like that, I think more wearable trackers or the app-based technologies are coming in that could take care of the screen time or monitoring the lifestyle. Okay, Solid, you're asking a lot of questions. Thank you. What about young adults who's escalate when at university? Agreed. It's a good question. Even in young adults, even in fact, we did a research recently. I think we found that 4% of the young adults aged 18 and above tend to have some sort of myopia progression. So, which means, this small percentage need myopia control options. So, age is only a number. I'm repeating multiple times. Even if it is young adult, you might want to start myopia control treatment. Now, according to me, there are two zones which are gray at this point of time. Number one, pediatric, early onset high myopia. You give some treatment. Will it work? There is less evidence there for these myopia control options. And then young adults, if you give this treatment, will you still see the same beneficial outcomes, or will the efficacy drop, or will it be better? So these are two extreme entities which need to be looked at. Question on dopamine mechanism. I'm not completely sure. My research on that is relatively less. But whenever there is the light exposure, especially the bright light exposure, the studies have shown that there is increase in the dopamine. The retinal amacrine cells, dopaminergic cells release this dopamine, and these high levels are good for eyeball. So which means it's a happy hormone, happy neurotransmitter. It does not allow the eyeball to grow. Now, there are also studies about what could be the effect of caffeine. I think there is a study that looked at if you add caffeine and if add caffeine in along with the atropine, will there be any beneficial outcome? This is ongoing research. I think there is also a publication on this which showed that the caffeine did not reduce atropine's efficacy, at least. And there is a new treatment where I did not tap onto that, but we're looking at 7-methylxanthine, a metabolite of caffeine already available in tested in Danish population. That's also made available. It's a tablet formulation that's also there. That is known to, I think, strengthen the collagen. That's what the animal studies indicate. Sunny has come with another question. Apart from Ortho K, any other FDA approved strategy? I am not aware. I think atropine is one of the treatment strategies that's been approved. Then I said only two questions, but there are more questions there. How to minimize hyperopic defocus? Now, I mean, see, these are patterns that naturally exist. The hyperopic defocus in the periphery could naturally exist. To counteract that, you might want to use peripheral defocus spectacles that changes the hyperopic defocus to myopic defocus. So that's the only way. You could use orthokeratology, you could use multifocal contact lens. When I say multifocal contact lens, ladies and gentlemen, I am saying center distance multifocal contact lens, because center distance, periphery near, more plus, more myopic defocus. Now, if there are researchers joining, I also want to maybe complicate this a bit. There is a poster at the ARVO recently that indicates that both the hyperopic defocus lenses, myopic defocus lenses work in favor in controlling the progression of myopia. So like I said, myopia is evolving. Everybody can contribute to this field, and every bit counts. So I request more people to do myopia research, because the ground is really empty. Everybody has their own hypothesis. I think there's a long way to go. Eye exercises help in myopia management. I do not have any evidence on that. Eye exercises to control the myopia management. But I think this is again an evolving area where there are studies slowly suggesting eye movement on the screens could help in with a specific pattern could control the progression of myopia. Again, I'm talking based on my learnings from the recent RO that happened in the month of May. Can you manage unilateral pathologic myopia? Yeah, unilateral myopia. Even if one eye alone is having myopia, one eye alone is undergoing the progression of myopia, you could give treatment to only that eye. If there is anisometropia, unilateral, I usually go with contact lens options for better binocularity. And I have one individual who is young adult, only one eye is progressing and the myopia is in control. I thank all the audience, people who are joining from different parts of the country, and I hope there is some learning from the today's lecture.